So is it full screen now with you?
Yes.
Okay. So all of you know that the ST segment is from the at the end of the, it begins from the end of why it's not coming. What I'm writing is not coming. It shouldn't be here. Okay, that's coming fine. So from this line, the ST segment starts from the end of the S wave to beginning of the T wave. And ST segment is always isoelectric. What do you mean by isoelectric?
It's neutral, neither positive
It's
or
neutral.
negative.
Neither it's going up or down. It's neutral, horizontal line, isn't it? But sometimes what happens? What is the possibility that this ST segment can be elevated like this? So what's happening now here? ST segment is not horizontal. It's getting up. From here, this portion has gone up. So now the ST segment is elevated. This is known as elevation of the ST segment. And when it is getting elevated, it's getting merged with this part of the T wave. So now it will come like this, complete curve will come. So ST segment will get elevate and it will get merged with the T wave. This is ST segment elevation. And ST segment elevation is a diagnostic of myocardial infarction. Diagnostic of myocardial infarction. But all the ST segment elevations are not myocardial infarction. Then what is the criteria? What is the criteria for myocardial infarction? Let's look into it. Okay. So there are three criteria for myocardial infarction. The ST segment elevation that is occurring here the ST segment elevation which you are seeing here from the isoelectric line. The elevation should be more than 2 small square. So the first condition is that the elevation should be more than 2 small square. The ST segment should get elevated from the isoelectric line more than 2 small square. The second condition is that the elevation should have convexity upwards. Can you see here? Can you make out here convexity upward in this elevation? All of you? Do you understand the term convexity? Convexity means if I am drawing this line, curved line like this, let me erase this one first. Okay. So this curved line has got convexity upwards. Can you make out? And if I draw the curved line like this, it has got convexity where? Where is the convexity?
Downward.
Downwards. This is what known as convexity upwards and the downwards. So for diagnosing as a myocardial infarction, the ST segment should have convexity upwards. And other way of looking it into, just draw the circle around the ST segment, okay, and you will get a crying face. You'll get the crying face over there. That's your heart is telling to you that I am dying, because your heart is crying and telling you that I am dying, I am not getting the blood supply. But in other way, you see this is also elevation here, but the convexity is downward, so this is not myocardial infarction. And when you draw the circle around the heart, it is forming a smiley. So your heart is telling, don't worry, I'm getting a proper blood supply. So till now, I told you the two criteria for diagnosing the myocardial infarction. First of all, the elevation of ST segment should be more than 2 small squares. And second thing is that the elevation with the convexity upwards. And the third thing is that the ST segment elevation should be in a more than one consecutive leads. more than one consecutive leads. What do you mean by more than one consecutive leads? First of all, you should know what do you mean by consecutive leads. Does anyone knows what do you mean by consecutive leads? We have I have told you before that each lead represents one area of the heart, isn't it? So when I'm telling consecutive leads, if I ask you what are the inferior leads, can you reply to me what are the inferior leads?
Lead
V2.
2, lead 3, AVF.
Good. Lead 2, lead 3, and AVF, these are inferior leads. Can anyone tell me what are septal leads?
V1,
V1,
V2,
V2.
Good. What are anterior leads?
AVL, V5,
Anterior,
V6.
anterior,
Oh,
anterior,
interior.
anterior. Sorry?
V3, 4.
V3, V4.
V3, V4,
V6,
good.
V3, V4. Yeah.
Lateral leads
Yeah, AVL, V5, V6,
and
and
Lead 1.
lead 1.
lead 1. Perfect. So these leads, whenever I'm telling that lead 2, 3, and AVF, there are inferior leads, it means that 2, 3, AVF, they are consecutive to each other. 2 is consecutive to 3, 3 is consecutive to AVF. They are related to each other. When we are telling V1 and V2, they belongs to the V1, V2, V3, V4, they belongs to anterior septal. They are consecutive to each other. Similarly, the lateral leads, they are consecutive to each other. So if you are seeing the change of ST segment elevation in only one lead, say for example, you are getting ST segment elevation in lead 2, okay? Only in lead 2, no other lead. In lead 3 and lead AVF, it's perfectly normal. So will it be myocardial infarction? No. To diagnose at myocardial infarction, the changes of ST segment elevation should be in lead 2 or at least lead 3. More than one lead, more than one consecutive leads. But if the change is coming only in lead 2 and AVF and 3 are normal, you will not diagnose it as a myocardial infarction. Similarly, if ST segment elevation is there only in V1, will you label it as a myocardial infarction?
No.
Yes. Will you label it as a myocardial infarction?
No. No.
Then which other leads you will look into?
V2.
V2, V3, V4, anterior leads. If it is there in other more than one lead, then only it will become myocardial infarction. So this is the criteria for diagnosing. Let's see some examples now. Okay. So the ST segment elevation which I was talking about, you see, can you note down the ST segment elevation here in V2? Can you make out? It should be here, isn't it? Ideally, the segment should be here, but it's going so high. You see the V4, V4, V5, V6. So which are the leads involved here? V2, V3, V4, V5, V6. What about V2 and V3 and V4? Which are these leads? Which area they belongs to? V2, V3, V4. Which area they belongs to?
Interior.
Anterior. What about V5 and V6?
Lateral.
Lateral. So these become anterior lateral myocardial infarction. You'll diagnose it here as an anterior lateral myocardial infarction. So these areas are important for us. These which area the leads belongs to which area here is in diagnosing of myocardial infarction is important. Now this is a whole. Come on, all of you. Can you make out where there is? What has happened? I stopped sharing or what? Oh, I'm sorry. I'm sorry. I'm sorry. I'm sorry. Okay. So can you make out now which we were on this slide or another slide we were looking at before? Okay, this we have seen. Okay. Come on, all of you. You have to work now. Tell me which leads are you seeing the ST segment elevation?
V1 and V2.
V1, V2. Anywhere else? What you says, guys? Guys are sleeping.
V1, V2.
Only V1 and V2.
Only V1 and V2. So which myocardial infarction you're talking about? What will be your diagnosis if you're telling only V1 and V2 then?
V3.
Anterior.
Anterior myocardial infarction, V1, V2, mainly septum. Well, you're right, anterior, acute anterior, or specifically you can say the septal myocardial infarction. Okay, come on now. Which leads? Please don't see the answers in your slides, huh? Please reply to me by looking at directly here to the screen. Don't look at your other slides. Otherwise, no benefit unless you practice like this identifying. Otherwise, no benefit. Come on, now I will. Now this is not chance for girls. Now this slide, the boys has to respond to me. Come on, guys, sleeping or run away.
Dr. Is it V4? V2? 3.
Sorry. One by one, please.
V1, V2.
V1, V2. This is V1. This is V2.
Lead 2, lead 3.
So there is in V1 or V2 there is or not? First tell me.
No, doctor, from
No.
V2, V3.
Sorry, lead 2.
V2, V2,
lead
3.
Lead 3. And what else? What else? Lead 2, lead 3, what else?
AVF.
AVF.
Doctor, I didn't
Inferior
get
wall
how,
myocardial infarction. Sorry?
I didn't get how to know exactly. Can you?
Sorry?
I didn't get how to know it exactly.
In the
Can you
previous
show?
slide, I explained. Can you make out here ST segment? What happened to ST segment here?
Not clear.
What is not clear?
Elevation, any sir?
Yes, definitely elevation. We are diagnosing myocardial infarction. Here, see, you put the line here. Can you see the elevation here? This one, ST segment is got up. It's not isoelectric. Can you make out here ST segment?
No.
Sorry?
No.
No, I am drawing the line. What? No. I am drawing this isoelectric line. Where is the ST segment now? It is going up or not?
Up, yeah.
That's what we are looking. That is
Okay.
elevation. So the ST segment is elevated in lead 2, lead 3, lead AVF, isn't it?
Clear.
And this is the myocardial infarction, inferior wall myocardial infarction.
Doctor, what about V1? There is a small elevation.
Where?
Consider it,
Where?
V1.
Where?
Yes.
You see, there is no elevation. Flat.
I think it's a small.
It should be more than 2 small square. Elevation should be more than 2 small square. I told you. Where is elevation? Flat.
Okay.
Clear?
Yes.
Okay. So this is inferior wall myocardial infarction. Next, let's go to the next slide. And now there is a chance for girls. Now boys will not talk. Come on, girls.
V2 and V3.
V4.
Somebody is telling V2 and
V3.
V3. V4 also someone is mentioning. Anywhere else?
V5, V6.
Sorry?
V5 and V6.
V5,
V6.
V6 also someone is telling. Anywhere else?
Lead 1.
Lead 1. Good to pick up in the lead 1. What about? Sorry?
VL.
AVL. Let's see whether you are right or wrong. Absolutely right. So what will be diagnosis here? Anterior lateral. You see, because the V2 and V3 are anterior. So this is anterior. And also now V5, V6, 1 and AVL is involved. So these are lateral. So these are massive myocardial infarction is there. Anterior lateral myocardial infarction. So this is very simple. Diagnosing a myocardial infarction is very, I don't know if I have one more example, I will show you. Otherwise, we'll move further. And last thing about ECG, I'll talk, and then I have to show you something else. Just a minute. Let me close this one. Okay. So that was myocardial infarction. That I have given you some sample of the. But don't worry, nobody is asking you to diagnose. Nobody is asking you to diagnose the myocardial infarction. Okay. So that was important of ST segment. What about the T wave? There is something about the T wave. Normally the T wave is like this. But can you see the T wave here? There is a tall T wave with a spike, just like the QRS. This is QRS and compare the T wave, how tall it is. So the tall T wave is a diagnostic of hyperkalemia. What is hyperkalemia?
Reflux of
Increase the
potassium.
potassium.
Increased potassium level, hyperkalemia. And what happens in hypokalemia? The opposite of that. The T wave is very flat, very low T wave. Sometimes even the T wave becomes inverse, and you will get it as a U shape, inverted T wave sometimes in severe hypokalemia. So tall T wave is a diagnostic of hyperkalemia, and flat T wave or inverted T wave is a diagnostic of hypokalemia. So you can make it out here. This is normal, and you see that now here the potassium level is 7. So you can see. Can you see the arrow which I am moving on the slide?
Yes.
Yeah. Okay.
Yes.
So now the potassium level is 7 here. You see, and how the T wave is elevated. Here the potassium level is gone more high, 8.5. Can you make out how tall is the T wave? Yes, very tall. And here now you see potassium level is going down, 3.5. So T wave is becoming flat. Potassium level here in the lower diagram is 2.5, and the T wave is completely become reverse, inverted. So tall T wave is diagnostic of hyperkalemia, and hypokalemia is diagnosed by inverted T waves. So can you see the tall T waves here in the chest leads? Yeah, these are diagnostic of hyperkalemia. So this is now just an example here. This is actually not actual real ECG, but if you see the panel A and panel B, the change here in the panel B, you will find ST segment elevation in 2 and AVF. And in panel A, there is ST segment elevation in lead 3. Which panel is diagnostic of myocardial infarction, panel A or panel B?
B.
Why? Why? You are
Because
right.
it's in more than one.
Absolutely right. Because here the ST segment elevation is in more than one lead. Here the ST segment elevation is only in one lead, so it's not the myocardial infarction. Here the myocardial infarction is there. Now similarly here, there is ST segment elevation. Which one? Which panel is myocardial infarction, A or B? Come on, don't read down. Just see the diagram. Boys, sleeping. Good morning. Hassan.
دكتور ايه
Dr. Hassan, sabah al khair.
صباح النور.
Which panel is
بانل ايه دكتور؟
infarction? Sorry?
بانل ايه؟
Panel A. Why?
بانل ايه ايه؟
Why? Because it has more than one lead showing the ST segment elevation. Okay. Oh, these are extra thing. And actually, this was all about the ECG. And there was one slide remaining for the girls. And no one has reminded me, I think, in the lab of the heart sound. I told you to remind me in the heart sound lab. But I'll open it for you now.
Doctor,
Yeah.
can you go back to the panel A, please?
Which one?
Last one, panel A.
Yeah.
Yeah. Just to make sure, can you tell me which one?
You tell me which one.
A, all of them, right? Or no?
Sorry?
A, all of them, right?
What do you mean by all of them?
All of them has elevation.
Yes.
And B only at V4 and 5.
Which one?
V4 and V5.
See here. Can you see the elevation?
Yeah.
Where? What about here? Can you see in V3?
Okay.
Can you
Should be
see?
immediately.
There is no elevation here.
So only V3.
Only V3.
Okay, thank you, doctor.
Okay. So now I'll open the slides for the girls now.
Doctor, before you close this one, about the anterior lateral wall, myocardial infarction, about AVL, there is a small falling before the elevation. Is it okay?
Which one?
In the anterior lateral wall of myocardial infarction.
Okay.
May you back to the slide? Yes, anterior lateral.
Yeah.
Yeah, about AVL, there is a small falling before the elevation. Is it okay?
Where is small falling below before elevation?
In the AVL.
Yeah.
Let,
There is no. Where is the fall? ST segment elevation. Where is there is fall?
after QRS finishing, there is a small fall after that
QRS
elevation.
is not finishing. This is QRS. This is a Q. This is R, and S is not reaching down. Here, S should be here.
Okay.
H should be here. But it's from here the ST segment is starting. Where is the fall?
Okay, tamam. Thank you.
Doctor,
Yeah.
can you go back to slide 19, please? I have a quick question.
Which slide?
Slide 19.
It was related to what?
Panel A and panel B.
Okay, just a second.
Yeah, sure.
Okay.
The one after this.
Okay.
Yeah, this one. So to me, V3 and V4, it looks like the same thing.
Which one?
Like it looks very similar. For panel A, V3
Panel
and
A.
V4,
Panel A.
yeah, and for panel B, they look
Why?
very similar.
Why? This is This is panel A here. This is panel. This is isoelectric line. This is isoelectric line. Why these both are same now? Tell me.
And for V3, doctor, like it looks
No,
like
why it is same here? V4. What is same here?
the shape, except the last parts.
This is the T wave, and the ST segment is here. Here the ST segment is here, and the T wave merge with the T wave. Then the T wave starts.
Okay. And
And
for
here,
V3,
V3 here there is elevation, and here there is elevation. So they will look same, definitely.
thank you, doctor.
Doctor, Rinad in the chat ask you.
Sorry.
Rinad in the chat ask you. There is some
Yes,
girl.
she can. She don't have this mic.
I think no, because she write it in the chat.
What is the question? Can you read now, please?
If there is elevation in V1 and V3, should we consider it as a myocardial infarction since both of them are on
Yeah, both are anterior leads. Yeah, you will consider it.
there
As
is
they are consecutive, V1, V2, V3, V4, they are consecutive to each other. So any two of these them will show you a ST segment elevation. It will be myocardial infarction.
the question, there is continue for the question. Should we consider them as the anterior or should be both in anterior or both in septal or both of them? She said.
Sorry? If it is V1 and V4,
If it's V1
it will be
and
anterior septal. It will be anterior septal.
no, V1 and V3, she writes, should we consider it as
Yeah,
a
it will be
myocardial
anterior
infarction?
septal. It will become anterior
It's
septal.
anterior and septal. So we join
Yes.
together the word. Okay.
Absolutely. Okay.
Doctor, if it was like V1 and V6, it's not myocardial, right?
No, these are not consecutive leads. It should be in a consecutive leads. It should be in a more than one consecutive lead. So if you are telling the anterior lateral, then it should be in V1 and V2, and in the lateral leads, then you are going there in the lateral lead. It should be either V5, V6, or more. One or V6 should be involved. More than one. Is there any other question here? Al Johra is writing in Arabic. Sorry, Al Johra, I will not. I cannot reply in Arabic.
No, I'm just answering Rina the question. I told her your answer. That's all.
Okay.
Doctor, is this included in the mid one or no?
Tell me your name.
Muhammad.
Yeah. How many times you will ask this question to me?
No, because this in the lab not included in the list.
That's why I'm telling how many times. Can anyone repeat my words in the labs or in the lecture? Can anyone? I want from girls or boys side to repeat my words related to ECG. Come on, guys. Who can recollect my words related to ECG?
Everything.
What was my words about ECG?
ECG is ECG.
Absolutely right. ECG, ECG, nothing like ECG 1, ECG 2. There is no like lab. Whatever I'll teach in lecture 1 will be asked in the mid exam and end block exam. Whatever I ask in lecture 2 will be asked in mid block exam and end block exam. Whatever I'll ask in lab will be asked in mid block, end block, and OSPE. Is that fine?
Doctor, do we have to calculate in mid one?
Yes, you have to. Again, this is the same question you are asking what he has asked.
No, I'm talking about the
No,
calculation.
that's what I'm telling. Whatever I said, what I covered in ECG is ECG.
Yes, sir.
Can we bring
Not
a
going in
calculator?
detail. ECG is ECG. Okay?
Can we bring a calculator to the exam?
No, not allowed.
Why?
Don't ask me. This is not the first time. We are teaching since 10 years. And after exam, none of the students complain to us.
Doctor?
Yeah.
Regarding the calculator, for example, in the heart rate, the normal
Yes.
one is from 16 above, okay? So for
Yeah,
example,
dear, we know about it. Dear, we know about it. And we know what can be done with the pen and what requires calculator. This much of IQ we have as a teacher.
no, I didn't
That's why I'm
finish
telling
that.
this much of IQ we have as a teacher to what type of question to be asked to the student and what can be done without calculator. This much idea we have as a teacher. Isn't it? Don't you think that if I am working 20 years in cardiology, I will not ask the question which cannot be solved without the calculator? You think I am that much stupid?
No, doctor.
Yes, that's all. Until now, no one has complained about my questions ever since I'm in Al Marifa. Is that enough for you? Okay.
Thank you, doctor, so much.
Let me now come to the girls. I was telling that some of this slide, about the cardiac cycle, the girls has not reminded me. And I will revise with the boys also at the same time. Why it's not moving? Can anyone show me? Okay. So I'll open another one now. What is this going on here? I don't know. Stop share. I had to share another one. Just now, I want to hear from the girls. What you forget? Tell me. From the cardiac cycle. Come on, girls. Can you hear me? Can you hear me? No?
Yes.
So what I have forgot about the cardiac cycle for the girls. No one knows?
Myocardial infarction, I think.
Myocardial infarction in cardiac cycle. Wonderful.
No, we just...
The relation between the volume and the pressure in the left ventricle.
Absolutely right. You forgot to remind me in the heart sounds lab. Why I'm not getting the slide, how to share it? Do I need to close this slide before sharing other, or what I have to do?
I think that's why you have to do, doctor.
I have to close this slide.
I think so.
Okay. And now another one. Okay. Can you see the slides now?
Yes.
Okay. So I want to boys to listen to me first. This is a revision for you, little bit, only one slide I will be revising. Don't worry, don't cry. But this is very important slide for you also for revision. This one I have done with you girls, isn't it? Girls?
Yes.
Yes, I have done this slide. But what was remaining was this one. And better picture is this one. This slide I want to discuss with you. Yeah. Okay. And this is known as pressure volume curve of the ventricle. Pressure volume curve. We have seen what are the volume changes, what are the pressure changes during the cardiac cycle, isn't it? During the previous graph. This graph shows you the volume and the pressure. These are the pressure changes in the aorta, pressure changes in the ventricle, and pressure changes in the last one is what? Atrium. Similarly, now we want to separate out the ventricle, left ventricle. And this is known as pressure volume graph. Here is the y-axis. This is y-axis. This one is y-axis. Let me take the pen. This is y-axis. And here is x-axis. On the x-axis, we are drawing the volume, blood volume here horizontally. And on the y-axis, there is pressure. So before moving toward this complete diagram, as I have explained to the boys also, let me explain the movement of the pen. Can you just concentrate here the pen? If I am drawing the horizontal line like this, so volume is increasing or constant?
Increasing.
Increasing. What about the pressure? This line, what it shows you about pressure?
The same.
Same.
Yeah.
And if I am drawing a curved line like this, what about the volume and pressure?
Both of them increase.
Both of them are increasing. Okay. Now
Only pressure.
pressure is rising, but the volume is constant. What about now?
Pressure is dropping.
Pressure is dropping and volume is constant. Yeah. Now
the volume is decreasing, pressure is
volume is decreasing and the pressure is constant. Okay. So these lines, if you understand now, we can understand this diagram. So I will start at this point now. I will start at this point of the cardiac cycle where mitral wall opens. This round here shows you a mitral wall opens. And we can label it as point A. Point A. Here the mitral wall opens. Which phase we are starting? Mitral wall. I want girls to reply now because the boys has already attended this class with me.
Isovolumetric contraction.
Mitral wall opens. Which phase is beginning?
Isovolumetric contraction.
Isovolumetric contraction.
Mitral wall opens. Which phase is?
The rapid passive filling.
Rapid passive filling phase is starting now. Mitral wall opens and the filling of the ventricle is beginning. That is rapid passive filling phase. Rapid passive filling phases. That is complete filling phase. But after here, as soon as the mitral wall opens, this is the beginning of rapid passive filling phase. And now during this phase, what happens to the volume of the ventricle?
Will increase.
Yes, you see now. So the arrow is moving towards right. Can you make out? This arrow is moving toward the right. It means volume is increasing. What happens to the pressure? When the ventricle will fill with the blood, what will happen to the pressure?
Decrease.
Why?
Because ventricle relax.
Ventricle is relaxing. Good. So initially what happens here? There is a twist. Initially there is a fall in the pressure because ventricle is expanding. So there is a little fall in the pressure. But afterwards you see the pressure is also rising. So from here to here, the volume is increasing because now ventricle is filling with the blood from the atria. Initially pressure drops a little, but then the pressure and the volumes both start to rise. And finally, a point will come where the pressure in the ventricle will become more than that of the atrium. What happens here?
Closing of the AV wall.
Mitral wall or AV wall closes, isn't it? We'll label it as a B, point B. Is there any other mechanical event is happening here? What other mechanical event happen here? When the
First heart sound.
good, the first heart sound will be heard here. At the point B, the first heart sound will be heard. Now, which phase we are starting now from here?
Isovolumetric contraction.
Isovolumetric contraction, because now mitral wall is closed and semilunar wall is already closed. Your ventricle starts to contract. And when the ventricle is contracting as a closed chamber, what will happen to the volume?
Increase.
Sorry?
Constant.
Volume will
Volume
remain
change.
constant. Why? Because now the aortic wall is already closed, the pulmonary wall is closed, and ventricle is just contracting. So neither blood is coming to ventricle in, or neither the blood is going out of the ventricle. So ventricle, when it's contracting as a closed chamber, only what will happen? Pressure will rise. Pressure will rise too much in the ventricle, but volume will remain constant. And a point will come where the pressure in the left ventricle or both of the ventricle will become more than that of the aorta. And what's happening here?
Closure of the aortic wall.
Closure.
Opening, sorry.
Opening of the aortic wall will happen, and this is a point C. Does it produce a sound?
No.
No.
Why?
Because opening of the
opens
heart,
up
the
the heart
blood.
wall.
Opening of wall only produces the heart sound. The closure of wall does not. Closure of wall only produces heart sound. The opening of wall does not produce any sound. And from here, which phase we are beginning?
Rapid ejection phase.
Rapid ejection phase. And during the rapid ejection phase, the volume of the ventricle is decreasing because it's pumping the blood out, but the pressure reaches to the maximum. Around how much approximately?
120
120 to 130. And after that, what happens as the volume decreases, now pressure also starts to fall, isn't it? During the, which phase this is?
Slow.
Slow ejection
slow ejection phase.
So completely this is ejection phase, rapid ejection, slow ejection, and a point will come where the pressure in the ventricle will become less than that of aorta, and that will close the semilunar valve. And here there is one more mechanical event is happening.
Second sound.
Second heart sound is produced. Which phase we are starting now?
Isovolumetric.
IVR.
Isovolumetric relaxation.
Isovolumetric relaxation phase. AV wall is the semilunar walls are closed. AV wall is already closed. Your ventricle is relaxing as a closed chamber. What will happen to the pressure? Pressure will fall.
Pressure will
What will happen to
decrease.
volume?
Constant.
Constant. And when the pressure will drop too much during isovolumetric relaxation phase, a point will come where the pressure in the ventricle will become less than that of the atrium, and here again the mitral wall opens, isn't it?
Yes.
And the cycle begins again. So now here you see I have given the name to these corners: point A, point B, point C, and point D. Similarly, I can label these phases 1, 2. This is just for our understanding. Number is not ideal. I can give any number to it. I can remove the name and I can give the number, isn't it? I can remove this name, whatever written here. I will remove the name and I can give the number. Is that fine? So you should be able to identify these phases. You should be able to identify these phases. What is this phase here without the number also? So, and even these points you should be able to identify. If graph is shown to you, what is this point A, what is this point B, what is this point C, and what is this point D. Is there any doubt about this slide, girls?
No.
Clear?
Doctor,
Yes.
I have a question regarding isovolumetric contraction.
Sorry, can you repeat the question?
I have a question about isovolumetric contraction regarding atrial pressure. So we said that it starts to raise. but it starts to raise because of the bulging of AV valve or because of the filling from lung or because of
because of the bulging from the AV wall.
so nothing to do with the filling of a blood from the lung, right?
Yeah, there is nothing to do because the filling has not yet taken place so much. Filling has started, but just now started, and it has not filled the atrium so much to rise the pressure. Definitely, because of the filling also, pressure will rise, but slowly.
So
but
maybe
you can see here in the pressure curve, you see this is a P wave, isn't it? Sorry,
yes.
A wave, then the C wave, and then the V wave come like this. So after the A wave, after the fall of the A wave, you see here, fall of the A wave, if you are expecting the filling, just imagine that there is no isovolumetric contraction phase. So because of the filling, the slow pressure will rise to the V wave. Are you getting my point? But suddenly, because there is isovolumetric contraction phase, there is a slight sudden rise, that is a C wave. Okay, so the sudden rise, that is jerk, that is coming in the wave, is because of the isovolumetric contraction, not because of the filling.
Because of the bulging of the AV valve, right?
Bulging of the AV wall in the atrium because of the isovolumetric contraction.
And we can say that in the rapid ejection, the atrial pressure is decreased because of the filling, right?
Sorry, during the rapid ejection?
In the rapid ejection, the atrial pressure is increased because of the filling, right?
Because of the filling, absolutely. And that's what the V wave is formed.
But at the first, there is a lot of falling. It's okay.
Sorry?
At the first, there is a little bit falling.
Where there is fall?
In the rapid ejection phase and the atrial pressure.
No, there is no fall. Okay. Where there is fall?
Okay.
This is a rise. This is a slow rise is happening. This is a rise, isn't it? This graph you are telling, this is a slow rise, not fall. This is a slow, because after the A wave, the pressure has fallen.
Okay.
And now from here, the slow rise is there. Are you getting?
Yes.
Not fall. Yeah.
Okay.
Any other questions you have?
In the rapid ejection phase, regarding the aortic pressure, we said that the aorta is expanded because we want the atrial pressure to remain lesser than the ventricle pressure. Is it that true?
No. No one said that sentence. No one has said that sentence that aorta expand because what you're telling? Atrial pressure should remain lower than the ventricle?
Yeah, to remain the valve open.
No, no one has talked about it.
So like why the expanding of the aorta in rapid ejection phase?
Who will explain me the expansion of aorta? Who will tell about the expansion of aorta?
Is it because of the ventricular construction is higher than the aortic? So it does create in the aortic, the AV valve, the bulging, which is recoil.
No. Why the aorta bulges?
To receive a large amount of blood from the
To receive the large amount of the blood. What is there in the wall of the aorta? What is there in the wall of the aorta?
Elastic wall.
Elastic tissue. There is elastic tissue, and because of this elastic tissue, when you pump a large amount of the blood in the rapid ejection phase, the aorta bulge, stretch, isn't it?
So
but there is one benefit we are getting out of this bulging. What is the benefit? Who will tell me? What is the benefit we are getting because of this stretching of the aorta?
The pressure of aorta doesn't drop.
The pressure of aorta doesn't drop during diastole. So what benefit we are getting out of it? Pressure of aorta is not falling during the diastole less than 80. So what benefit we get out of it?
The valve will remain open?
Nothing to do with the wall.
The flow of blood
the flow of the blood will continue during the diastole. During the systole, your ventricle is pumping the blood into the vessels, but during diastole, the ventricular pressure falls. But as the aorta that is expanded because of receiving of the large amount of the blood will give a elastic recoil now, and that recoil will pump the blood forward. Okay, is that clear?
Yes.
Is that clear? Who has asked me the question?
Me, Jahara. Yes.
Is that clear?
Yeah.
Okay.
Thank you, doctor.
Any other questions you people have? Any other doubts you have?
Doctor, could you Remember you explained this before, like
Little loudly, please. I cannot hear your voice.
doctor, you explained this before in the cardiac cycle in the graph that after slow ejection phase, that the aortic pressure in the IVR would actually increase due to the closure of the valve, and then the bulge would basically like push all this blood, so the pressure would increase temporarily for the aorta. Could you explain that one more time?
I'll come to the previous diagram. What you're talking about, I will come to the diagram and. Okay, we're talking about this, isn't it?
Yes, doctor.
You're talking about aortic pressure here?
Yeah, the aortic pressure after slow ejection phase, where it just like temporarily rises up.
This is ventricular pressure, and now this is aortic pressure curve that is drawn. Okay. So you're talking about this phase?
Yes, doctor.
Yes. Which is this phase? Can you label this phase first of all?
This is IV or isovolumetric
Isovolumetric
relaxation.
Relaxation phase. And you are asking why there is a rise of pressure here in the aorta.
Yeah.
Yes. Now I will ask first your colleagues if anyone can recollect from my lecture.
This thoracic notch.
Yes. Why this notch appears here?
Because of the recoil.
Because of recoil. Absolutely right. Who has asked me the question?
Me, Dr. Nawaf.
Nawaf, just now you have listened, two questions came to us. One question was about the elastic stretch of the aorta during the ventricular ejection, isn't it?
Yeah.
I explained that during the ventricular ejection, the aorta expands because of the elastic tissue in the wall. And what happens during the isovolumetric relaxation phase, during the diastole, the aorta that has expanded will give a recoil, elastic recoil. You understand the recoil?
Yeah, the recoil.
Will come back.
Come back.
And that comeback of the aorta is giving this little rise in the pressure here. And that is known as dicrotic notch. Is that fine? And that is helping us in pumping the blood during the diastole. This increase in the pressure in the aorta that's happening is helping us in pumping the blood forward.
Okay.
Clear?
Yeah, thank you, doctor. Very clear.
Right. Yes, any other question from any lectures, from lecture 1 to ECG complete? Any questions? Any questions you have? No one? All doubts are clear?
Me, doctor, I have a question.
Yes, go on.
Doctor.
First, ladies first, then you.
It's okay, he can start.
No, go on.
Okay, so regarding isovolumetric contraction, all valves are closed, but at the end of the isovolumetric contraction, there is open. So if you ask us about the valve in the exam, we say it in the isovolumetric contraction, it's always closed, or at the end it will open.
During the isovolumetric contraction, all are closed. Definitely, you're right.
But at the end, it will open.
At the end, it will open. Isovolumetric. At the end, it will open, not during.
The answer.
Sorry?
What will be the answer if you ask
What is the question? First, tell me the question. Then I'll tell you the answer.
In the isovolumetric contraction, always the valve are closed, right?
Yes. First of all, this question is wrong. Nobody can write a question like this in the exam, that in isovolumetric contraction phase, always the valves are closed. Usually the question structure is wrong. So I don't agree with the question. Okay. So like this way, the question cannot be asked about the cardiac cycle.
Okay.
I may ask during the isovolumetric contraction phase, what is the condition of valves?
Close.
AV valve close, AV valve open, semilunar valve close, semilunar valve open. What might be the condition? Isn't it?
Yes.
Or I may ask at the beginning of isovolumetric contraction phase. I may ask at the end of isovolumetric contraction phase. Particularly where? During, beginning, or end?
At
but
the
I
end.
will not ask in. In is not right sentence, right word.
Okay.
And always is not a right word. We never make question with always.
Okay.
Never.
And the last question about ejection, slow ejection in the aortic pressure, is it falling or rising?
During the slow ejection phase.
Yes.
Yeah. Here is the phase. You see, aortic pressure. This is the this is the ejection phase completely, isn't it?
Slow ejection phase.
Yes, this is a complete ejection phase. And if you divide it into half, this is a rapid ejection phase here. Okay, till here is the rapid ejection phase. Now you tell me what's happening to the aortic pressure.
Yeah, it's going down.
Yes, it's going down. The pressure is going down. Why the pressure is going down? Why the pressure in the
maybe
This
because
blood ejection.
because now the less blood is getting ejected into the aorta from the ventricle, isn't it?
Mm-hmm.
And now at this moment during the ejection phase, during whole of this ejection phase, the ventricle and the aorta, they are acting like a single chamber because the wall between them is open. The aortic wall is open. So whatever the pressure changes is happening in the ventricle will be reflected in the aorta. So pressure in the ventricle is also falling, pressure in the aorta will also fall at the same time.
Okay.
Isn't it?
Yes. In the isovolumetric contraction, the aortic pressure will remain the same or 80 will stay?
It will remain at
80?
80, absolutely. Because now which valve is closed?
All
wall is closed, including the aortic. So no blood is getting ejected into the aorta. That's why the pressure will remain at 80. Yeah.
That's all. Thank you, doctor, so much.
Anyone else? Yes, from one boy was asking me a question.
Doctor,
who is he?
Doctor, yeah, Doctor, me.
Hassan.
Yesterday, Doctor, I was asked about the second lecture in elective vestigial
Yeah. What was the question? Can you remind me?
In applied heart blocks, you told me I will talk about it tomorrow.
Okay,
and bundle branch block.
Okay, just let me show you here in the blank slide. Can I open the blank slide here? How to make it white?
Press W, doctor.
Sorry?
Press W.
W only.
Yeah. Or B.
Yeah, W. Good. So here, my friend has asked me the question. So,
beautiful heart.
Absolutely. That's why I say girls are always better than the boys. These all are bakhil. Agreed, Hassan?
Yes, of course.
Yeah, I get it.
Agreed, bakhil. Yeah.
In the class, you say the opposite.
What I say? If you don't respond, it will change. My statement will change according to the situation. Isn't it? Just like a cardiac cycle, this is a life cycle. It will go on changing every moment. So now this is SA node. And he's asking me about the block, different types of blocks. His question is about different types of blocks. So sometimes what happens, SA node is firing an impulse, but these impulses are not conducted to the atrium. There is a block here immediately after the SA node. Immediately after the SA node. SA node is working, but it's not conducted. So what this block is known as? What is the name of this block? Sinoatrial block. Sinoatrial block. Another type of block is here, which we have talked more about during the ECG also. What is this block known as?
AV block.
AV block, because this is at the junction. Here the AV node and the bundle of his, there is a block. So this is known as AV block. And there is 3 degrees of block, the first degree, second degree, and the third degree, which we have talked about in ECG. Now after that here, after the AV node and bundle of his, there is a bundle branches here, bundle branches. What are the name of these bundle branches?
Right
bundle branch, left bundle branch, isn't it? Right bundle branch, or left bundle branch? Sometimes these bundle branches can block. So if the right bundle is blocked, this is known as right RBBB, right bundle branch block, RB, 3 times B, right bundle branch blocked. And sometimes the left bundle can get blocked, and this is known as LBBB, left bundle branch blocked. Are you getting my point?
Yes.
Yeah,
Yeah. Is that clear now, Hassan?
Yeah, it's clear.
Three types of
it's
block.
cool.
Yeah. These are conduction block. These are 3 types of conduction blocks: sinoatrial block, AV block, and bundle branch blocks. That can happen. And there are different types of changes also reflected in ECG depending upon these blocks, but we have not talked about. I just told you about the AV block in the ECG, but there are different pictures in the RBBB and LBBB. Actually, I have not given anything in the ECG. I have just given you can say, a drop of taste of the ECG. I have given you the taste of ECG. If you like it, you can proceed further. There are too much in the ECG. We have just given some samples, some examples, that's all. Anything else, guys?
Hi, doctor.
Doctor.
I have a.
Yes.
Hello. Hi. Yeah, I have a question. It's
Okay.
about the hexaaxial system, one that we did yesterday.
Okay.
Could you just please explain it to me, because I don't really understand it.
I'll go back. Just
thank you.
So which lecture? It was ECG2. Okay. Okay, you talked about the hexaaxial system, isn't it?
Yes.
I told you that we are drawing the 6 axes in the circle to measure the angulation of the axis in the heart. So I told you from where these axes came, why we are telling hexaaxial system, and from where these axes are drawn. These axes are coming actually from the 6 limb leads. You know, there are 3 limb leads, 3 bipolar limb leads, lead 1, lead 2, and lead 3. And they forms the triangle around the heart, which is known as Inthobian's triangle. And if you just break this triangle to meet it in the center, now how many axes you got in a circle? 3, isn't it?
Yes.
Yeah.
And now 3 more, we have 3 more limb leads, AVR, AVL, and AVF. So this is now 1, 2, 3, AVR, AVL, AVF. Let's combine all of them. Lead 1, lead 2, lead 3, AVL, AVR, and AVF. So now we got the hexaaxial system. And this is a circle, and you are in this circle now, you are having a heart in the center. So these 6 lines are actually the 6 limb leads. Is that clear?
What do the numbers mean, though, doctor? The
Sorry?
minus 120.
These are degrees. These are angles. These are angles.
Okay, okay.
Yeah, 30 degree. You see, this is a 0 line. This is a 0 to a horizontal line. This is a 30-degree angle. This is a 60-degree angle. 90-degree angle. Are you getting now?
Yes, yes.
And from here to here is 180, and here to here is 180. Again, total is 360. Circle.
Perfect. Thank you.
Yes, some girl was also asking the question.
Yes, doctor. About hyperkalemia, we don't have a specific criteria like myocardial infarction, right?
No. Only only they are comparing it with the hyperkalemia you're talking about. How tall should be the T wave? Only they are considering, they are comparing with the QRS complex. So the tall T wave is considered, if it goes more than half of the QRS complex, it is considered as tall T waves.
Doctor, I have a question.
Yeah.
For the second degree of IV block, the difference between type 1 and type 2.
Yeah. So, yeah, go on. Come on.
Just want
What
to
you're
know
asking?
the exact difference between them.
The exact difference between them. Okay. So these are this is type 1. In the type 1, only the PR interval will be prolonged. Okay. This is type 1. This is the second degree heart block, Mobitz type 1. This is second degree Mobitz type 1. Sorry. Here what's happening? When you say second degree, some beats are conducted, some are not. This is the first criteria. Okay. So here you see, here the first P wave. First P wave is conducted. Second P wave is conducted. Third P wave is conducted. But the fourth one, there is no conduction to ventricle. That's why QRS complex is not there. That's why we are telling it's the second degree heart block, because some are conducted, some are not. But now here you have to look at the PR interval. PR interval here is 1, 2, 3, 4, which is normal. If you see in the second complex, 1, 2, 3, 4, 5, 6, 7, 8 increase. Again, see in the third complex, 1, 2, 3, 4, 5, 6, 7, 8, 9, more increase. So PR interval was normal, prolonged, more prolonged, and then the beat is missed. When you get this pattern, that there is a progressive prolongation of PR interval, this is known as Mobitz type 1. Mobitz type 1 block. Mobitz type 1 second degree. Another type of second degree is type 2. Here also you see some beats are conducted, some are not. This beat is conducted, this is not, this is not. This beat is conducted, this is not, this is not. This is conducted, this is not, this is not. So this is second degree. But are you getting here the progressive prolongation of PR interval? No. You see, 1, 2, 3, 4. PR interval is normal. 3 to 5 small square is normal. Same here, same here. So what's happening here? Either the beats are conducted normally or not conducted at all. Not like the previous example, there is a progressive prolongation, delay, then the beat is not conducted. Not like this. Only either conducted or not, which is known as all or none phenomena. And whenever there is all and none phenomena, this is second degree type 2, Mobitz type 2. Is that clear?
Yeah, doctor. Thank you.
Any other questions?
Doctor, could you show me the difference between atrial fibrillation and atrial flutter?
Atrial fibrillation and atrial flutter.
The only difference I could pinpoint is that the regularity, like this atrial flutter is regular.
Here in atrial fibrillation, first thing that is there in atrial fibrillation here is irregular. Okay. One thing, first most important thing is irregular pattern. And here the fibrillation waves, the atrial waves, that is known as fibrillation waves. If you count the atrial rate, it is above 350 beats per minute. Okay.
Okay.
And if you come to the flutter, here there is a regular rhythm first of all. And the flutter waves or atrial waves, if you count them, it crosses 250 beats per minute. So between 250, but it will not cross 300 beats per minute like the atrial flutter.
Okay.
Sorry, atrial fibrillation. So the rate of atrial tachycardia is above 300 in fibrillation, but in flutter, it's between the 250 to 300.
Okay, perfect, doctor. Thank you.
Okay, this is the main difference. And definitely then the look what you are getting here in the flutter, the type of the waves, this is known as flutter waves. The look is totally different. than the fibrillation waves. Fibrillation wave is just sort of a vibration going on in the membrane, just sort of a vibration, not big waves. Okay. But these things are already, you don't get stress of these things. Atrial fibrillation, atrial flutter, myocardial infarction. Nobody is telling you to diagnose. Nobody will give you, we will not give you an ECG and tell you to identify what is an abnormality there. There's two things, always remember, we are not asking you to diagnose. We will not give you an ECG and tell you to diagnose what is there. You should only understand the concept and you should say what is, how we can diagnose. Say, for example, if I'll say, I'll not give you an ECG and ask you that whether there is a myocardial infarction or not. But I can ask you that one of the following changes in the ECG is diagnostic of myocardial infarction. Okay, now I'm giving you an MCQ. One of the following changes in the ECG is a diagnostic of myocardial infarction. All of you are listening? And there is a four option. There is four option: tall T waves, ST segment elevation, ST segment depression, and prolonged PR interval. What will be your answer?
ST segment
ST
elevation.
segment elevation.
Yeah. You see, now I have asked you about the abnormality. I have asked you how to diagnose it, but I have not asked you to diagnose. This is the difference. Are you getting my point? So at your level, we are making it easy. We are not putting you in trouble by giving an ECG and telling you to diagnose. So don't look at the bulk of the 3 lectures, what we have given to you. Don't look at the bulk. Actually, the concept is very little in that bulk. So don't get afraid of that bulk, ECG1, ECG2, and ECG3. No. Only if you understand the concept, you will be able to answer my questions. Is that clear? Any doubt you have?
Yes, doctor, I have a question regarding SCG2.
Regarding?
QRS duration. In some slide, like in slide number 18, it's written from 0.04 until 0.12. And in another slide, it's written 0.8 to 0.10. So what we should stick to?
Actual number, actually this was, I forgot to tell you in the class. The ideal number which cardiologists follow, is 0.04 to 0.10. That is one small square to 2.5. 2.5.
Okay.
And actually in some of the books, theoretical books like Guyton or some other books, they are mentioning up to 0.12, 3 small square.
Yeah, that's why I'm asking, because
But,
I read...
but the cardiologists clinically don't accept that. So I will tell you to remember 1 to 2.5.
Okay.
I will tell you to remember 1 to 2.5. One small square, 0.04 to 0.10. This is the ideal one. This will be good for you to remember. So you will continue till the clinical side. Nobody will change you. Okay.
Okay.
0.04 to 0.10. One small square to 2.5 small square.
Okay.
Is that
And
fine?
yes, it's good. And another question regarding BR interval and sinus bradycardia. We said that some of them, they are for small square, and some of them, they are 3 small square. Even if there is different, we consider it normal, it's okay?
Sorry? What? Some of them are 4 small square?
Yeah, and some of them, they are 3 small square.
Where?
So there is different in the sinus bradycardia. Slide number 21.
No, that particular slide, leave it. One example, don't follow that example in the slide. That is just to show you the sinus bradycardia, okay?
Okay, so in general...
Don't get it. Generally, normally it remains constant. But if, as far as it is within the normal range, no issue. As far as it's not crossing the 5 square, everything is normal.
Doctor, I mean that in PR interval, the general
Yes, I'm
one...
telling PR interval, the highest value. What is the highest value? 5 small square.
Yeah,
3 to
that's
5 small square. So as long as it does not crosses the normal range, it is normal.
That's not my question, doctor. I mean, for example, in one ECG, I have B wave that's, for example, 3 small square, and another
P
B wave...
P wave or PR interval?
BR interval, sorry, BR. In one ECG, In one PR wave, there is a 3 small square, and another PR wave, there is a 4 small
That's
square.
what I'm telling. As far as it is within 5 small square, it is normal. That's what my answer is.
Even if they are different from each other?
Yes.
Okay.
If within normal range, if it's not crossing 5 small square, it is normal.
Okay, that's good. And one last thing, should we specify the arrhythmia to tachy or pericardia or not? Just we say arrhythmia and that's all.
Which type of arrhythmia you're talking about?
Doctor?
Just let her finish, yeah.
I mean, atrial fibrillation and atrial filter or flutter. I don't know.
Actually, arrhythmias, we are not going into the depth of arrhythmia with you. Only we have given the concept of arrhythmia. Ideally, there is a classification of arrhythmia, and according to the real classification, there is supraventricular tachycardia and ventricular tachycardias. This is one type of arrhythmia. This is one type of arrhythmia I'm talking about. There are different classes are there. Then after that, WPW syndrome comes. Then the different another types of arrhythmia comes that we have not taught to you at all. Okay.
For example, for the atrial fibrillation, it's supraventricular arrhythmia.
Absolutely, this is one of the class of the type of supraventricular arrhythmia, supraventricular tachycardia.
We don't need to say supraventricular tachycardia, for example. Just say arrhythmia and that's all.
When you don't need to say when.
In the atrial fibrillation, supraventricular arrhythmia or supraventricular
it is a type of supraventricular tachycardia, but exact diagnosis is atrial fibrillation. The classification is supraventricular tachycardia, but the diagnosis is atrial fibrillation.
So if it's right supraventricular arrhythmia, it's okay without tachycardia or pericardia, right?
Supraventricular tachycardia. There is no supraventricular arrhythmias.
Oh, okay.
Yeah.
That's all. Thank you, doctor.
Okay. Yes, anyone else, please?
Yes, doctor, I was saying, sorry for interrupting, but we have a lecture with Dr.
Yes, that's why I want to finish it up. Yes, so now good luck for the exams, and from now onwards, Dr. Mujib is going to teach you, okay? CVS block.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.